what is research into supportive care? So two bits to that really, isn't there? There's what is research and what's supportive care. So as you've heard, I'm the director of the Candlelighters Supportive Care Research Centre, which is a new Candlelighters and CCLG funded initiative. We're coming up to our first anniversary. It's 5 years. We are determined to make things better in terms of supportive care. And if you want to know more about it, Pastor me or Deputy Director Jess at the back there, who'll be coming on talking in a few minutes about all this stuff later. But what we think of as supportive care is essentially everything that isn't the chemotherapy, picking it, the surgery, how to do the choppy bits, the radiotherapy, where the zapping happens, everything else. All of the adverse effects of the cancers directly, all of the side effects of the medicines, all of the adverse effects of having cancer on the young person, their family, their extended family. All of that is supportive care. It's a lot, isn't it? So, we work with lots of other people. But what sort of research can we do? What would be the best sort of research to do supportive care? Let me move on to an icon. Young person with cancer, mid-treatment, but still out there. What's the best research in supportive care? What's the best biscuit? What's the best biscuit, Jess?
Marks and Spencer's white chocolate rounds. Very specific.
Very specific. Are there any other biscuits that are actually better than Marks and Spencer's white chocolate rounds?
Jammy Dodgers. Custard creams.
Jammy Dodgers, custard creams. Custard creams?
Ginger thins.
Ginger thins.
Chocolate.
Chocolate hobnobs. Hobnobs without chocolate. Chocolate-less hobnobs. Shortbreads, classic.
Chocolate shortbread.
Garibaldi.
Chocolate shortbreads, Garibaldi, almost unspellable.
Bourbons.
Bourbons. At last, somebody has come up with the correct answer. If I was preparing the best biscuits and I knew Jess was going to be there, I would make sure that there were Marks and Spencer's white chocolate rounds on the table, because they are the best biscuits to deal with that particular problem. In a research sense. It might be we have a very different problem that requires the application of ginger thins. And if you didn't know exactly what you were doing, then maybe you'd start off with a table with some Jammy Dodgers on it. Maybe a few hobnobs, chocolated and unchocolated. And then some bourbons, because they're actually the best. And see what sort of audience you had. And it's the same with research. The best research is the stuff that is going to make a difference for that particular question, research question you've got in front of you. And why? Why do we do it in the first place? Well, we do it because otherwise people will take the Nike logo and they will leap forwards. You see, if someone's got a new chemotherapy or a new way of chopping people open or a new way of zapping them with high energy zappy things, on the whole, they don't just go, "Ooh, I've made this stuff in my shed. I tell you what, I'll give it to some children and see if it makes the cancer go away." For loads of reasons, mostly because we would arrest them as they were trying to bring it in. But they do studies, they do research. What about if somebody says, "I've got this app that's going to make teenagers feel better when they're having cancer, because it's going to give them all the tools they need to make them feel better. I know, because I was a bit pissed off, and I wrote this app and it's going to make them better." And they just launch it into the App Store. And they advertise it over Instatalk. And people start using it. And there's no actual research on them. But what harm can it do? Well, we've still got a legacy of stuff that we do that we think was the right thing, and then we test it and we go, oh, maybe it wasn't actually right. For instance, there's a chemotherapy agent, doxorubicin, you've heard about it. It's brilliant at making things shrink in front of your very eyes. Tumours shrink, loads of tumours shrink when you give them doxorubicin, go like that. I mean, if you listen hard enough, you probably hear the sound of them doing it. But just because it shrinks doesn't mean that it's going to go away forever. And until you start thinking, what do I really want? Not just what can I see? And you might get the studies wrong. And we were in a situation where we were thinking, let's pour more and more drugs on these things. Let's make them more and more shrinked away. It's going to make a difference. And sometimes in the 80s and 90s, we thought, let's take it the ultimate. Let's give people so much chemo that their whole bone marrow will need to be replaced. And that massive chemo will make it go away. And a bunch of Americans did this for breast cancer because the breast cancers were coming back causing problems. And they gave bone marrow transplants so they could give massive doses of chemo. And they found that there were fewer people alive at the end because they died of the toxicities of the treatment. And yeah, it's a bit less breast cancer. Not the point. The same can be said of our supportive care studies. So there's a really, really brilliantly sold drug called Cafosol that makes your mouth better. Except it doesn't. Because when we did the trial and half the kids got the Cafosol, brilliant drug, half the kids got nothing, the pain profiles were absolutely identical. Now, has anybody here been in the sea and got a mouthful of seawater? Yeah? Cafosol is essentially concentrated seawater to be taken 4 times a day. Even if it does nothing, having to do that to yourself or the 3-year-old that you're looking after is a horrendous negative. Do not just do it. Do trials. Because mucositis, some of you will know from seeing this happen in front of you, is an horrendous complication where your entire mouth turns into a mouth ulcer to the point where you can't swallow your own spit. And Harry wants us to keep using this picture, particularly to audiences that aren't clinicians, just so they point out that not all of cancer treatment is a nice thing. His lips are swollen, he's knocked out on a morphine drip effectively, and he hasn't been able to swallow his own stringy spit. Magic lights, I didn't believe. We've got a magic light expert there in the green dress at the back, Claudia. But a guideline came out saying use magic lights, photobiomodulation. Do we believe guidelines? Yes, if they are based on collecting all of the evidence together. A whole series of trials lined up in a systematic review. Systematic reviews, we go out, we get all the evidence, we add it up to get the best answer we can. We'll be hearing lots more about systematic reviews in a few minutes. But in order to do that, a whole load of people volunteered to be part of a coin toss, where half of them, heads, got the magic light and half of them didn't. And in this setting, the people who didn't get the magic light came off worse. But it's not guaranteed by any stretch. Take the Cafosol example, exactly the same. There are others where the new idea ends up being worse. And if you look back over the history of children's cancer frontline trials, then about half of them are right and half of them are wrong. Which is just the position we should be in. Because it means we're making a reasonable guess about what's going to take us forwards. But what about supportive care trials? We know lots and lots about putting chemo trials together. But who's asking the questions about, can we prevent infections? Can we make mucositis better? Can we actually put apps out there that make people feel better rather than just get advertised by some X or Facebook or LinkedIn star? And what about the things that you can't trial? Like what happens when there's a global pandemic and a virus comes in and tries to destroy everything? Well, how about you get a network of 20 centres of paediatric oncology, hematology centres together, use that expertise and draw in every case of coronavirus that you can find in children that are undergoing treatment, so that you can add it up in real time to work out what are the effects, what are the complications we're seeing in kids that are immunosuppressed, immunocompromised, and then put that information back out again so that you're leading, not following, leading the information and making that science turn into reality in real time. That's supportive care research. What about every time a kid on treatment gets a fever and has to go to hospital because they might have a really, really serious infection, febrile neutropenia? We know that half of those kids, more than half of those kids, haven't got a really serious infection, don't need to have tons and tons of antibiotics and get stuck in hospital. But how can we separate those out? Can we develop prisms to split the white light of them turning up into the rainbow of high and low risk of infection, and then put them into place so that we can actually change what happens and get kids home within a day rather than stuck on the hospital for 5 days? Well, with enough work and enough drawing together information from thousands and thousands and thousands of episodes, yeah, we can do that. This is mostly just so that you can enjoy yourselves.
Thank you, Bob.
You're welcome. It's also a vague reminder, in a vague sense, that not all things work in all geographies. So for instance, in most places, in most times, if you're wearing a single piece of clothing around your middle, like a skirt, then mostly that's a signature that the person wearing it sees themselves as female. And then there are other situations where it is strikingly and positively not the case. And if we're doing research, we should be thinking, is this going to work in all settings, in all geographies, in all areas? Because it might not. By all means, clean your glasses and have a better look. And so when we had this new way of splitting the febrile neutropenics and getting them out into the world, we ran, alongside putting the programme out there, a national review of what was happening so that we could feed back in real time. Is this a safe thing to do? Is it effective? Is it working in all these different sorts of centres, not just the ones that we'd got information from in the first place? And yes, we safely got about 20% of the kids out within 24 hours or so. But when we looked at the differences between the centres, this is the proportion kickouts, these are the centres, wide variation. And we went out and we said, why does it vary? And they went, oh, we're special. We're more special than you. We've got special patients because they're special, because they're ours. More work needed. And when do we stop antibiotics with this lot anyway? I mean, when they've not been hot for a little bit, for a bit longer, when we want to send them home, when they're at home. How many times do we ask that question every week? How many times as a parent have the syringe of medicine in their hands going, They're fine. I'm having to pin them down to give them this stuff. Why do I have to keep giving this antibiotic? When was the time that we had a clinical trial to answer that question? Never. We need more studies. We need to draw together all of our trials of anti-sickness, and instead of just look at one of them, add them all up in a massive, massive systematic review that will pull together information from children and grown-ups, because grown-ups are basically big kids that get treated in roughly the same way sometimes, and grown-ups throw up as well. Of course, kids are a little bit different when it comes to being sick, because they put themselves voluntarily through this puke-making activity. And so we have to be just a little bit cautious. So we have to do the science to make sure that this is the case. But what we really need is a place that's going to draw together these sorts of studies, to promote them as good research, and to get more researchers in this field out there doing those studies that we need. That's not to say we don't need the lab, we don't need the discovery, we don't need the drugs, we need all that stuff as well, but we need this too. And we need to know what's the right questions to ask first. So we went out and we asked a bunch of kids, of these things, what's the most important things we need to do when we're looking at the supportive care questions? We gave them all things, and Claudia ran a session where she got them to try and brush their teeth because she's a dentist, and also asked these questions. And they said the least important was, how do we make it easier for children to do schoolwork during treatment? So least important, I think it was almost off the end of the table and was drawn back in for the photograph. But their top ones were about, how am I more normal and more like my friends? How can I feel more normal during treatment? That's the kids' stuff. We asked the grown-ups and we asked the health professionals, and their top stuff was about infection prevention, and it was about soreness prevention. And for them, the image stuff was a bit lower. And the school stuff was a lot higher. And so we're doing stuff. We're doing a trial to try and prevent infections during acute lymphoblastic leukemia treatment. We're improving the way we think about that febrile neutropenia and splitting and risk stratification. We're looking to see, are there new sciencey things that can tell us when we can stop the antibiotics safely, so that we don't just generate more sore bums and destroyed intestinal microbiomes? We're looking to see, can we actively and meaningfully support parents and indirectly support their children through the heart-wrenching experience of going through this? This is a drawing done by a lad who was 12 at the time, at the back end of his induction treatment for acute lymphoblastic leukemia, describing what he felt it was like to his family. We're thinking about what happens late on, when you've had eye cancer as a baby, and now you're a teenager and entering into the world. We're working out, do you have to be stuck in hospital having your chemo? Or could you just grab a backpack and wander around with it, pumping into your body through the deliciously sunny streets of Leeds? And is scanning always the right thing to do for people? Or does it just generate unwarranted stress and unacceptable pressures upon services that are restrained with no actual benefit? And now we've got the magic lights, how the hell do we make doctors actually use the bloody things? And can we work globally to bring together this evidence into clinical practice guidelines that clinicians will follow? That means they don't have to do the research themselves, and they can just pick up the best tips and tricks from around the place and get them done. And can we maybe stop the big bogeyman of invasive fungal infection, which I hope many of you won't have heard of, but is essentially where bread mold starts to grow inside the lungs or potentially the brain of patients that are heavily immunocompromised. What can we do to stop that happening? And what about looking to the future? We start treatments and we say, this might affect your fertility in amongst everything else. Can we do something that's actually going to get that information across in a way that is manageable to young women, young men, as they're about to enter into this journey, so they can make a sensible decision for themselves? Or we can hand them a booklet. Wouldn't it be better if we had an interactive video with short little segments, more like they're used to seeing, that they can step through and then bring questions to their doctors? Yeah, let's develop that. Because all of that is supportive care research that needs doing. Yeah, we've got brilliant ideas, but let's make sure they actually work, and that's what our supportive care research centre is all about.